Undersecretary Dobriansky announced an additional $28 million. So our total pledged for this international preparedness and response is now $362 million. We are moving quickly to disperse these funds, and we've urged other nations to do likewise. And we believe there's been great progress, but much, much more remains to be done. We've provided, and this is just some examples, technical assistance to develop preparedness plans in 46 countries. We've conducted outbreak simulation exercises. We've provided supplies, protective equipment, and experts on surveillance. We're trying to build human and animal health capacity, improved communications within countries, collaborative research on animal vaccines, and technical assistance to the World Health Organization and to the Food and Agriculture Organization, trying to give them an emergency response capacity. The U.S. is spending some $66 million to develop international stockpiles of health supplies to contain animal and human outbreaks. The United States' initial stockpile of antivirals has been positioned in Asia for possible use in that region. We've provided $36 million to support the work of international organizations that I mentioned earlier, WHO, FAO, and OIE, and also $41 million for international research activities worldwide. We're supporting more than 25 nations' efforts to improve their laboratories, diagnostic capacity, and surveillance systems. So, in many respects, we can look back and say there's been great progress. Much has been done in the last year, ever since September, really, when President Bush announced the international partnership at the UN General Assembly. But much more needs to be done.
I want to emphasize that this is not a U.S. problem alone. This is a Western Hemisphere problem. This is, in fact, a global problem. And right now I'm concerned about it as how it impacts birds, wild birds. But we don't know where it's going to come in. We just don't know the pathway by which it moves. Migratory birds are a possible pathway. I would argue it's the least likely pathway. And I think we need to really pay close attention to how we move poultry, legally and illegally around the world, and exotic pets, wild birds, both legally and illegally. And we need to understand how we quarantine these things. In the U.S., our quarantine facilities are state-of-the-art. They're really working well. I don't know what's happening in other parts of the Western Hemisphere that might be importing birds for the legal market. And that could bring it here to the Western Hemisphere, and then the migratory birds could subsequently move the virus. The dead bird surveillance program is a U.S. focused program. It's called DBIRD for dead bird, and it'll be a web-based program using bird watchers, citizen scientists, as our first line of defense, people that actually find the dead bird. That's the challenge, is finding that dead bird event. Once we find the dead bird event, then we can investigate that. But that's the challenge, is finding where that dead bird's occurring first. It's a Smithsonian-initiated project, and we're hoping to work jointly with U.S. Fish and Wildlife Service, USGS, perhaps USDA, and the Cornell Lab of Ornithology will also be a big player in this.
About halfway done.
Yes. Well, maybe it's
Okay. There are scientists now on campus who are evaluating strategies that might be useful in increasing its immunogenicity. So there are a lot of things going on. But it seems unlikely that that vaccine will actually be the vaccine that we'll need, because the H5N1 strain is the avian flu, and we don't know yet what the pandemic isolate will look like. And that'll be the virus that we'll need to have to make the vaccine strain. Compared to other pandemics of my lifetime, Way more thought has gone into this, way more planning has gone into this, and the healthcare machinery has geared up in the country in a way that we've never done before. I mean, do we have a ways to go yet? You bet. I mean, this is, as you can see, it's a highly transmissible, contagious disease, and so it's a huge problem. But I think the country is doing a great job in terms of getting ready.
Understand that at the clinical center, because of patient privacy purposes, we can't have just patients being shot.
I understand that.
The government, the Department of Health and Human Services, has granted $1 billion worth of contracts to 5 companies to be able to scale up their capabilities, particularly in making a transition from an egg-based culture system to make virus for vaccine to a cell-based, which is much more efficient and has a greater scale-up capacity. So the department is jump-starting the system to be able to get to that point where you can actually rapidly scale up. One of the things that's being pursued now that we have not utilized with the standard seasonal influenza vaccine is the use of adjuvants. And an adjuvant is a compound which you give together with the vaccine, which amplifies or expands its immune response. There are 2 advantages to having a successful adjuvant. One is you could probably get a better, more robust immune response to the vaccine. And the other is that you might be able to get away with a lower dose of the vaccine to get to where you want to be with regard to protection. If that is true, if we're successful in that, that would lessen the burden of the scale-up capabilities that we don't have yet about being able to make a lot of vaccine in a relatively short period of time. So one of the technologies that is being pursued is the use of these adjuvants together with the vaccine. In general, if you get an isolate, you can get within a period of weeks that isolate growing to the point where you can grow it in eggs or in cell culture or what have you. And then you start just producing it, and as you produce it, it's a matter of a couple of months to get some doses, to get the amount of doses that you need on a regular seasonal basis. That usually takes about 6 months. Let me give you an example. If we pick out the strain of virus that we want to make for the 2006-07 season, we've already done that. We made that decision somewhere at the end of January, the beginning of February. It was grown for a few weeks, adapted to eggs. It's now growing in eggs, and it will likely take about 5 or 6 months sometime in the middle of the summer to get enough to supply the people who need it, and then you start packaging it, putting it in the vials, getting it ready to go so it's ready to roll sometime in October and early November. Well, we're the agency that is primarily responsible for first understanding the biology of the viruses, the kinds of fundamental basic research and scientific questions that you ask, but importantly, is for the development of what we call countermeasures. So we're primarily involved for the development of a vaccine. We're primarily involved for the development of new drugs. So those 2 issues, drug development, vaccine development, all superimposed upon a basic science effort to understand the virus better.
He's very polished looking.
Oh, okay.
These guys saw
want to
that
go down to the cyber cafe for a couple minutes, you know, really, go ahead.
That'd be great.
Yeah, go ahead.
If you
Because it
want to
might
stop
be
it.
another 45 minutes for lunch.
Yeah.
But I'm hoping we'll get there early.
All right, let this run. possession. It's this little.
We're working with our partners, and our major partners are ministries of health in countries around the world, WHO clearly, other partners such as UNICEF and so forth, to develop what we're calling the Global Disease Detection Response Centers. We currently have 3 that are functioning and 2 more that are in development. The 3 are in Kenya, Thailand, and Guatemala, and we're looking to develop additional ones in Egypt and in China. The idea behind these centers are to develop centers of excellence to work in collaboration with our partner country ministries of health to identify and train health professionals who are able to more rapidly identify emerging disease health threats, respond to them in such a way to limit the likelihood that a small local problem will become a big global problem.
Typically, there will be 20, 30,000 chickens in a house, and this contains those chickens. They are kept there from the time they are brought as baby chick until they are taken to the processing plant, all in, all out, which means we can control them. We can really monitor their health and their well-being by having them all confined in a place. They have plenty of room to walk around, but it does mean that they won't be infected by a bird from outside or be influenced by a bird from outside. The farmers are all trained at what avian influenza, on that subject, they're trained to observe what the symptoms would be in the event that the disease were to occur. And they immediately would contact our company's officials, and then we would immediately contact the state veterinarian in which the farm is located. We have a comprehensive testing system where every flock in the United States, in our system and in the commercial industry, is tested before processing, so that at least we have a good idea that flock is free of the virus. You cannot, from eating fully cooked poultry, if it is handled properly and cooked properly, chicken is perfectly safe. The virus is killed by the cooking process, so there's no danger from eating cooked poultry.
These biscuits are making in hats and all. But we have one North Carolina,
Olive oil.
And the lake, and the expertise on that sort of thing.
So where are they?
They don't get moved from right
So when
there.
we're talking about a farm, and it's like...
These are people who are well-trained.
There you go, just got.
Because it's only, I don't know how many you get, but it's not that many. But it's a...
Wait, the chicken part.
Do you eat chicken every day?
Just about, or in one form or another,
Okay,
because
ready?
you can have chicken sandwiches,
Put my
and
glasses off,
even
though.
sometimes for breakfast, there's a chicken biscuit that some of the restaurants offer that's good. So,
So
Yum.
the name of the farm, is that the company's name or the...
Okay.
I would have gotten that.
Well,
The H5N1 virus first affected humans in 1997 in Hong Kong. Since that time, the virus has mutated and been spreading in chickens and birds and has infected persons around Asia, in Africa, and Europe, and caused very severe illness. Fortunately, to date, the virus does not spread efficiently from human to human. So virtually all of the cases come from exposure to infected birds. But the fear is that this virus will mutate and become efficiently spread from human to human and cause a worldwide pandemic. There are three criteria for a pandemic. One is a new influenza virus to which virtually the whole world's population is susceptible. Number two, that it cause human disease. And number three, that it spreads efficiently from person to person. The H5N1 viruses have met those first two criteria. The big concern is that these bird viruses, or avian viruses, will simultaneously infect someone with a human influenza virus, exchange genes, and have a human-adapted virus that will spread efficiently from person to person. There are no cases at this point at all of either bird or human cases of H5N1 influenza. There have been human-to-human transmissions elsewhere in the world, but they are extremely rare, and they have been associated with very intense, prolonged contact. The current vaccines being used to prevent seasonal influenza will not protect against avian influenza or H5N1. But it's important to realize that when you get vaccinated with today's seasonal vaccines, you do several things. One, you protect yourself against the most likely strains to circulate. And number two, you help build production capacity. Because one of the big concerns we have with avian influenza is to rapidly produce large numbers of vaccine doses. And if we don't have that production capacity, we'll not be able to do that. The current vaccines that have been tested in humans have required very large doses of protein, up to 6 times as much as a standard dose, and 2 doses. And that's because humans haven't any experience with the H5 virus. What's needed is to look for ways we can stretch the vaccine supply, such as adding chemicals called adjuvants, which help the body make an immune response to a smaller dose. Looking at ways of delivering the vaccine differently, such as into the skin, which may allow us to give smaller doses. One of the ways of compensating for the need of large doses is to build our production capacity to produce those large doses. And one of the ways we can do that is to increase our efforts at routine annual influenza vaccination to prevent seasonal influenza. Number two is there are chemicals that can be used to potentially boost the immune response so you could get a good immune response with smaller dosages. 3 is to build in surge capacity. Right now, vaccines are primarily made in embryonated or fertilized chicken eggs. And that's not very responsive to a surge in demand. And so if we can switch that production into production in cell cultures, which are readily available, we can increase our surge capacity and potentially produce those large number of doses. There are major efforts underway to try and produce vaccine in cell cultures. There are limited manufacturers who have licenses for this, but for the most part, almost all of the influenza vaccine around the world today is produced in fertilized chicken eggs. One of the problems with influenza viruses is they change and mutate. That's why we have to give a vaccine that's different every year, because we often have different flu viruses circulating each year. The H5N1 virus that's currently circulating has already mutated from the past, so that if we make a vaccine against today's H5N1 virus, there's absolutely no assurance that it would be effective against an H5N1 virus causing a pandemic. The important thing is we need to have early detection. We need to buy time and see which virus is actually circulating and will cause the pandemic, and make a vaccine specifically against that strain. Most experts feel it's about 6 months to get the first doses off of the line. Some people have talked about shortcutting it to 3 or 4 months, but 6 months is a reasonable planning for getting the first doses off the line. So we need to try and have surveillance around the world to try and pick up when this virus or whatever virus will cause a pandemic is spreading, to buy time to make enough doses of vaccine. A big challenge for vaccine distribution is not having the infrastructure in place in most areas to vaccinate the entire population, which is likely what we would want to do in the event of a moderate to a severe pandemic. We don't have in the United States right now the ability to vaccinate 300 million Americans. The most we've ever vaccinated is about 83 million. So we need to build that capacity, and in much of the world, the infrastructure is even less. Many countries don't even vaccinate against seasonal influenza.
With the mask.
Do you have anything in a closet so we could actually show? That would be kind of interesting. Maybe if I displayed it and said this is...
Like gloves?
Yeah, no, come on.
No, go ahead.
Really won't walk by like this.
Well, I know what that is.
I like
Part
that
of it
actually.
had to be
That makes a good video.
You want it?
Well, Sam was recommending if we do an interview that we do it in one of the express rooms.
All right, let's
Which is a smaller version of one of these.
Is it, do you think, better than
You guys moving out?
Yeah.
I don't want to leave him waiting on his stuff.
Yeah.
And then if you just want to kind of see
What would we use, like, in the event of testing? What would this be used to test blood? Yeah. I think it's not one of the methods.
If it was avian flu, then would it be tested here, or would it go to the CDC, or how?
But we'll probably come back and do that.
Okay, great.
Well, I think it would initially be tested here, but if they were looking for specific CDC, if they were looking for bird flu,
We do not do that in this spot here. So microbiology. Okay. Oh, okay. Would you, let me ask you this. You don't have to be on camera, but I wouldn't mind if, after we do the interview, we could sort of take some of these things. And if you don't, would you mind if we had your voice explaining what they are? Like this is, so like journalists may know, they use this visual, they it's B-roll, like to shoot with the room looks like? With the bed?
You want to shoot this right now?
Don't even look at
Yeah,
it.
well,
A drain tube.
what is this piece of bill?
That's a, this thing right here, that's a lot.
This is a hematology analyzer, and one of the features of this particular analyzer, if we have a patient with an infectious process going on, our employees are protected because we have closed container sampling. The instrument itself will puncture the cap on the tube, and the employee does not have to open it and expose themselves to the aerosols coming from the tube. So this is a safety feature for us in the laboratory. So that you observe patient's blood, and then you count the cells that are different.
I'm doing a manual count, which is called a differential count. I'm comparing what the instrument has told us that it saw, but it flagged something abnormal, so I have to make sure that what I see here is what the instrument read. Basically is what I'm verifying, a count on a patient.
So yeah, I guess if we just need
Basically, the section of the laboratory we're standing in now is our clinical virology lab, and what we do here is essentially would provide the specific etiologic diagnosis for an influenza-like illness, and we have a number of methods at our disposal to do that. Basically, what we rely on primarily are culture-based methods. A physician would collect a sample, typically an NP swab, and send it to the laboratory with the question, I think my patient has a viral illness, which one is it? And the testing we do here would provide that specific answer, would provide the answer to whether it's a viral illness and which of the various viruses that can cause influenza-like illnesses is a problem in that particular patient. So right now, we have an epidemiologic link to guide us. So the scenario would be that a patient has traveled from a region of the world where there's concern about human avian influenza. We would do the testing. We would either confirm or deny that an influenza A virus is present in that patient, and then we would have to refer that sample on to, in our case, a state public health laboratory that has the capability to determine whether that influenza A virus is in fact avian influenza. The role of the laboratory in terms of establishing a specific diagnosis of influenza sort of changes with the prevalence of the disease. Laboratory testing for influenza is most important at the beginning of the influenza season to define when the virus actually enters the community. And if it's a relatively mild influenza season, then it's important to be able to sort out the different causes of influenza-like illness. If a true pandemic actually happens, or when a pandemic happens, the role of laboratory testing isn't quite as important because by definition in a pandemic situation, almost everybody that you would see, a physician would see with an influenza-like illness would have influenza. So the role of the laboratory in sorting that out isn't as important. And besides, in a true pandemic situation, we wouldn't have the resources to keep up with the testing.
Okay, let's go.
You want an introduction, or what do we want?
We will get an introduction.
One of the things that we have done here at Emory is that we are preparing a stockpile of personal protective equipment here to be for access during an emergency purpose, whether or not it's pandemic flu or maybe an active bioterrorism, because certainly personal protective equipment is probably the thing that we're going to run out of the quickest. And so we're concerned that we have enough in-house here to protect our workers. We have been given federal money to purchase emergency preparedness supplies, and the idea is that with all of the hospitals participating in this group, we all have purchased the same kind of supplies. So from hospital to hospital, item A is the same at hospital B and C and D, and the fire people know which supplies the hospital has, and they also have the same types of supplies, so we can support one another in the event of an emergency. There are things like masks and eye protection and gowns and gloves that the way the hospital works today is that they have what they call just-in-time supplies. So we don't really have a lot of supplies like that around. They come in on a rotating basis, and by establishing a stockpile, we would at least have access to more of those supplies rather than just a 2-day or 3-day limit on them. Right now we're in progress with the Georgia Department of Health to try to set up syndromic surveillance at the state level, and what we're trying to do is integrate our emergency room data with data sources that they're already collecting both from the schools and from the pharmacies to look at do we have things going on in our community that otherwise would go undetected. In the face of a pandemic, you know, maybe things change and the rules change, and day to day there are different rules depending on how things are evolving.
Someone who gets it from a bird and gives it to the family is something we've seen before. Of course, it does concern us because the more of those events that occur, the more likely it is that we're going to have those viral changes which are going to make it better for going between individuals. So we would obviously like to see none of those occur, but as of now the virus is still not a very good infectious pathogen for going from person to person. It would be individuals who have contact with birds. Most commonly, it would be poultry farmers. Now, of course, once we get into the third world, where lots of families raise ducks and geese and chickens and frequently live in close proximity to them, those obviously would be individuals who would also be at greatest risk right now. The clinical course as of now is really no different from what most people associate with flu. There's usually a high fever, 101 to 103 degrees, a diffuse body ache, what we call muscle aches or myalgias, frequently headaches. If it involves the lung, as it frequently does, you can get coughing. One of the characteristics would be a cough where you don't bring up any sputum. It's just a diffuse inflammation of the airways and of the lung tissue itself. In terms of going to your physician, again, it would really depend on the individual. If we have a young, healthy individual and they have a slight muscle aches and some low-grade fever and they're still able to keep things down and drink fluids and stuff, there would be very little that a physician would be able to do for them. On the other hand, if it's somebody with pre-existing disease, heart disease, or especially lung disease, those individuals would be wise to seek
medical attention because they might deteriorate very quickly. The Public Health Service has a series of practices around the United States. And these physicians and other healthcare providers, when they get patients who look clinically as though they have influenza, they will do cultures on them and send them to the laboratories. And that is really the only way that the Public Health Service comes out and says, this is the virus which is in your community. And we will probably not know initially that somebody has the avian influenza until they present to a practice where they are cultured and the laboratory tells us, in fact, that this is an avian strain and not one of the more traditional strains that we're used to seeing. Until we actually have the virus which is causing human infections, we will not know how effective these antivirals are. There have been some strains in Southeast Asia of the avian influenza which were resistant to Tamiflu. Most people probably are aware that the strains of influenza which were in the western United States this year were very resistant to Relenza and to the more amantadine and rimantadine, the more traditional agents. So the bottom line is, until we actually get the virus and test it in the laboratory, we will not know which antiviral agents will be most appropriate for treating those strains. And we will be basically guessing when we treat the first patients until we get information from the laboratory. A lot of thought has gone into the stockpiling of antiviral agents, the mechanisms that we will use to distribute vaccine to healthcare workers and our patients, and just the entire way that the healthcare community is going to respond to what will be a big load on an already strained system of healthcare. When we identify the initial patients, because we will not know how contagious their virus is, they will be treated in the highest level of isolation. In our particular facility, Emory University Hospital, we have a unit that we're sitting in now, which has been specially designed to take care of patients with the most highly contagious, most serious infections. And a patient coming in with our initial cases of avian influenza would be taken care of in this facility. As we get more experience with the virus and we discover how transmissible it is, we will determine what level of precautions need to be taken for further patients as they present to the healthcare system. Our system is really a graded response. For a few patients, as I've said, we would treat them in this highly contained facility. If, on the other hand, our worst case planning comes true and we actually have to treat 100 or 200 patients at a time, we are looking more at cohorting by either rooms or, in fact, sometimes by whole units. And we even have the possibility for opening up other units which are away from where we care for our traditional patients. One of our greatest fears is, in fact, that somebody will come to an emergency room, not be identified initially, sit in a crowded waiting room for 2 to 6 hours before somebody realizes that they have this contagious infection, and potentially transmit it to a number of other people, not just patients, but family members waiting in the emergency department. Our plan actually calls for, once we know that avian influenza is being transmitted to person, to keep these people out of the emergency department, which is already strained and it cannot cope with the patients it normally handles. And in fact, part of our response plan talks about establishing triage stations outside of the emergency department, perhaps even outside of the immediate facility of the hospital, to safely care for these individuals and not have them mixing with our traditional patients who have a number of other illnesses which would place them at grave risk for influenza infection. Depending on how sensitive the virus is, we may very well take our most at-risk healthcare workers and give them prophylactic antivirals so that they won't get sick. Unfortunately, that takes a lot of medication, and if we're having a lot of people who are coming in because they're acutely ill, we may not have sufficient supplies to give preventive treatment to our healthcare workers. We've also at least discussed the option of having the workers who are caring for these patients not go home to their families or community, but rather stay here, either in our hospital on-call rooms or perhaps using one of the dormitories that the students would normally occupy. People who are ill will be asked to stay home if at all possible. They will certainly be advised not to go into areas where large numbers of people congregate. It would not be a good idea for somebody with influenza to spend 3 hours in a movie theater or a play. We will advise school-age children or workers that if they're ill, they should not go to school or to work. We will also advise individuals who are well that if somebody in your environment is obviously ill, those individuals need to be strongly encouraged to leave that environment. Metropolitan Atlanta has a very elaborate plan which involves all elements from the hospitals to the county to the state health department to the quarantine station at the airport. We have a number of plans, some of which are still in transition. We've met a number of times. We know each other. What will be most important is we know how to communicate in a hurry, because whatever we plan for, the actual presentation will be different. We're absolutely certain that we will have an influenza pandemic in the United States. I think we can also say with certainty that we don't have a clue when it will occur. What we do have to say is that we need to be vigilant, be constantly looking for individuals who are ill with influenza, and be prepared to rapidly act on it when it does occur. We could do better, but I think we've gone a long way towards being prepared. In the influenza planning community, we often talk about the fact that there are 4 outcomes that may occur from a pandemic or planning for a pandemic, and only one is favorable. We may do lots of planning and nothing will happen, in which case everybody will say we've wasted our time. We can do lots of planning and yet the event can overwhelm us, in which case everybody will say, well, you didn't plan well enough. We can do no planning and we will have a pandemic and everybody will say, well, why didn't you plan for this? Or we can do no planning and we won't have a pandemic, and then everybody will not know that we didn't even devote any effort to it. So of those 4 scenarios, only the do no planning and have no epidemic or pandemic is a positive one.
This unit was developed to take care of patients with the most highly communicable serious infectious diseases. There are only 2 units like this in the United States at the present time. We have one here and there's one at the University of Nebraska. There are several units that are in the process of being developed around the United States, and our unit is frequently used as the model for them.
That's what I want.
Don't get the Ambien. I give like my Ambien.
No Ambien. Slide them all off and grab them. There you go.
And with red, your red light and your Ambien.
And all you want is
they're both for the end. Yeah. So what works on the age? Well, I think they
ready
both
to
come.
go.
They are. I don't know that.
Can't imagine what else we need.
Yeah, that's one of my.
All righty.
It's true.
We basically have enough supplies for our own first responders and our employees that are in the hospitals. We don't have huge supplies that will take care of the community or anything else. Of course, we're working with at the national level and state level with the national stockpiles and chem packs at the federal level and state level that would include the drugs that are antiviral and will take care of those systems. But the Tamiflu are basically the first responders and our employees for the hospitals. There's Tamiflu and Influenza, but at this time we're only going with Tamiflu, and that's the only drug that we're currently going to use, and we're going to start with that and go from there.